Good morning and welcome back to GP Video Podcast by Nadia. So today we are doing menopause part 3. I have already spoken about what is menopause, which is the last day of last menstrual period, perimenopause, months or years leading to menopause, and then till the 1 year completion of the first year completion. So perimenopause starts when the symptoms start, when the cycles are going to get anovulatory, without ovulation, hormones are going to go up and down. It could be, for some women, it could be few months. For some women, it could be few years, leading up to the last day of last menstrual period, which is menopause. And perimenopause lasts up to 1 year after the menopause. So this is called perimenopause, while postmenopause is after 1 year of menopause. So menopause, perimenopause, postmenopause. What is the actual age of menopause? Any time between 45 and 55 years of age, and the average age is 51. Anything before 45, anything before 40 have been given different terms that we will discuss some other time. But yes, anything before 45 is early menopause, which we will discuss later. But yes, so 45 to 55 is the actual age of menopause, especially in Australian women, and average being 51 years of age. So anything happening after 45 years of age, which can classify as menopausal symptoms, because estrogen and progesterone are the hormones that go up and down. And of course, after menopause, they are down. That's why all the symptoms happen, because estrogen and progesterone receptors are all over in the body, including brain, cardiovascular system, gastrointestinal system, bones, everywhere. So whatever the symptoms happen, including psychiatric or mental symptoms or physical symptoms, they all can be attributed to menopause, including brain fog, mood swings, weight gain, hot flushes, because vasomotor symptoms that we call, because it happens with the estrogen receptors on the vessels. Vasodilatation causes all the vasomotor symptoms, like hot flushes, night sweating, weight gain, brain fog, mood symptoms, feeling just irritable, all those kind of symptoms that you can that come in the perimenopausal area, and that cannot be attributed to anything else. And so these are all perimenopausal symptoms that happen, and they can be treated. They should not be taken lightly, because what happens is, because estrogen affects all the areas of the body, all the systems of the body, if we do not treat menopause, especially the menopause which is symptomatic, if we do not treat that, then it's going to be really bothersome. The quality of life is going to be affected. And after menopause, if estrogen is not provided, then there are so many chances of getting cardiovascular problems like heart attacks. Bone density is going to get decreased. So osteoporosis is one of the other dangers if we do not give women HRT. So I'll come to this topic again, that which women should really be treated and which women can wait and not get treated. But generally, my personal point of view is HRT should be given to everybody until and unless they have those 3 to 4 contraindications that I spoke to you about the other day. So which were what? Which were any active cardiovascular disease like stroke or heart attack, any active like recent or active cardiovascular disease, current blood clots, personal history of breast cancer, uterine cancer, cervical cancer, or any other reproductive or hormonal cancer that is estrogen and progesterone dependent. These 3 are the risk factors for like absolute contraindication. So whatever is the absolute contraindication, only those women should, and actually those women can also get non-hormonal treatment, because menopausal treatment can be divided into hormonal and non-hormonal. So these women who have absolute contraindication to hormonal replacement therapy can definitely get non-hormonal menopausal therapy, while the ones who do not have any contraindications should definitely get hormonal replacement therapy. But of course, that's my own view. But there are some, points to clarify which women. Definitely those women should get who get any kind of symptoms. So that is another thing. But yes, so when we start talking about hormonal replacement therapy, how do we decide what to do? So again, the criteria comes back to if the woman has uterus, if the woman does not have uterus. If the woman has uterus, she will get both estrogen and progesterone in the treatment. If the woman does not have uterus, then only estrogen. Okay, and I explained the reason yesterday that what happens is, if the woman has uterus, estrogen fertilizes the lining of the uterus while progesterone keeps it thin and it does not let it become so thick and change into endometrial cancer. While if the woman does not have uterus, because there is no lining, so we do not need progesterone, because it is basically the estrogen that treats all the symptoms. So progesterone is there to help estrogen to modify its effects, especially on the uterus. But when a person does not have uterus and does not suffer from endometriosis, then we do not need to give progesterone to the ladies. We only need to give estrogen, because estrogen is the thing that is the hormone that actually acts all over the body. It's not progesterone, it's estrogen that acts all over the body and controls all the symptoms related to perimenopause or menopause. So that we have decided. After that, the question, usually I'll talk about cyclical and combined later, but usually it is said that if we put an IUD of Mirena, which releases progesterone, and use an estrogen patch, that is the best way to deliver hormone replacement therapy. So Mirena IUD with progesterone and an estrogen patch would be the best way to do it. But then again comes the question of cyclical hormonal treatment and continuous hormonal treatment, and we will talk about it tomorrow. Have a great day.